which is being presented via Zoom. My name's Andrew Lloyd, and I'm the head of the Viral Immunology Systems Program. And it's a pleasure to welcome you today to this seminar, actually on behalf of the NHMRC-supported ASCEND program, which is a partnership between investigators here in the Kirby and the investigators from the National Drug and Alcohol Research Centre. To start the seminar, though, I'd like to begin by acknowledging the traditional custodians of the lands on which we gather today, and to pay my respects to their elders past and present. Today, we are presenting from the lands of the Gadigal and the Bidjigal people of the Eora Nation. And I'd like to extend my respect to the Aboriginal and Torres Strait Islander peoples joining us today here in the audience and online. Can I mention just a couple of housekeeping items to start off with? So the format for the seminar will be two presentations, one of which is actually by video because our presenter is from Bristol, is in transit, followed by a Q&A session in probably equal parts. However, can I just encourage you to ask questions throughout the program using the Q&A button at the bottom of your screen. So today's seminar is focused on the prison setting. And you may be aware of this, but the prisons are an interesting and complex organisational system, which is characterised by a population, that is the prisoners, with really very high healthcare needs. But it's a physical environment in which the access for healthcare provision is very challenging. And amongst other things, the opportunities for prevention and intervention are constrained by the fact that the population is very dynamic, moving between centres and moving between the prisons and the community, amongst many other layers of challenge. So today's seminar actually is merging that interesting environment with the opportunities provided by mathematical modelling. In particular, modelling to inform the public health response in terms of policy and practice and in cost effectiveness analysis for infectious diseases prevention and management. And we're going to hear firstly some case study of hepatitis C and some modelling applied to that. And then secondly, of COVID-19 in the New South Wales prison system. So to start the ball rolling, our first presenter is Jack Stone, who sent his apologies because he's in transit, like I mentioned. Jack's a research fellow from the Bristol Medical School at the University of Bristol in the United Kingdom. But he's also a visiting fellow at the National Drug and Alcohol Research Centre at UNSW. And his research has focused in particular on mathematical modelling and cost-effectiveness analysis to help understand the transmission of infectious diseases, and he's done a lot of work in the prisons, understanding the impact and cost-effectiveness of intervention and prevention measures. So without further ado, I'm going to ask now, Richard's going to actually share the video with you.
To present this work that has been collaboration between myself and others at Bristol and Andrew and others at UNSW. So I'm going to give a presentation today about two sort of projects that we've been working on. So I'm going to begin with an introduction and then talking about some modelling looking at the impact of prison-based interventions for achieving hepatitis C elimination among people who inject drugs in New South Wales. I'm going to talk about a sort of follow-up project that's been looking at the cost effectiveness of scaling up prison-based treatment for hepatitis C, and then just wrap up with some conclusions from both studies. Okay, so as way of background, people who inject drugs are at very high risk of hepatitis C infection, with over 50% being exposed to hepatitis C globally. Now, due to the criminalisation of drug use, people who inject drugs experience extremely high rates of incarceration, with around 60% of people who inject drugs ever having been to prison globally. And this leads to a disproportionately high prevalence in correctional settings. Previous studies from around the world really have shown that a history of incarceration is strongly associated with prevalent hepatitis C and HIV infection amongst people who inject drugs. So a few years ago now, I conducted a systematic review to see whether being recently incarcerated was associated with acquiring hepatitis C among people who inject drugs in the community. And we found that it was associated with a 62% increased risk of acquisition. When we did our subgroup analyses, we found that this increased around to just under 180% in Australia. So this previous modelling that I've done elsewhere has shown that incarceration through this increased risk can be an important driver of hepatitis C transmission among people who inject drugs. But also that prison-based interventions can have significant impact on the overall epidemics amongst people who inject drugs. So one of these interventions is hepatitis C treatment, and the advent of direct-acting antivirals, or DAAs, in the last decade has really revolutionized treatment, with cure rates now exceeding 95%. Previous modelling studies have suggested that hepatitis C treatment can prevent transmission by reducing the pool of prevalent infections. So this is a concept that's known as treatment as prevention. Now, with these modelling studies and also the advent of DAAs, the WHO have set ambitious targets for eliminating hepatitis C as a public health threat by 2030. And within these targets is an 18% reduction in hepatitis C incidence compared to those levels in 2016. Now, of course, because the high burden, people who inject drugs are a high priority group for elimination efforts. In New South Wales, 53% of people who inject drugs have ever been incarcerated, so very similar to the global average. Opioid agonist therapy, which is treatment with methadone or buprenorphine for people who have opioid dependence, which reduces drug-related mortality, but also the risk of acquiring hepatitis C. And this has high coverage in prisons and is comparable to the community coverage, although a little bit lower. In Australia, there's been a recognition of the importance of prisons for hepatitis C transmission, and also the opportunity that they provide to scale up DAAs. And so specific initiatives have been put in place to ensure universal access to DAAs for prisoners. What this has meant is that not only has the number of DAAs treatments in prisons increased every year, but also the proportion of treatments that occur in total that occur in prison. So prisoners only constituted 6% of individuals treated with DAAs back in 2016, but this has risen progressively to nearly a third of all treatments in 2019. So what we wanted to do was look to see how important these prison-based interventions are for achieving elimination. So to do this, we developed a mathematical model, which was a dynamic compartmental model of hepatitis C transmission and incarceration among people who inject drugs in New South Wales. And the model stratifies people according to different characteristics. So we have duration of injecting, incarceration status, people's hepatitis C infection and treatment status, and opioid agonist treatment. Now, in terms of our incarceration, we stratify population similar to how it's been done before in other settings. So we have those that have never been in prison, those that are currently in prison, those that have ever been incarcerated before, further stratified then by whether they've recently been released or whether they haven't been released in the last 12 months. So reincarceration happens at a rate faster than incarceration. And then the model assumes, based on my earlier systematic review, that this period here where people are recently released from prison have around a 180% increase in transmission compared to others in the community. In terms of in prison, we calibrate the transmission risk in prison to give the difference in the antibody prevalence among community people who inject drugs with and without a history of incarceration. So by doing this, we don't fix the transmission risk, and it can be either higher or lower in prison than in the community. So to parameterize the model, we used data from a range of sources, but primarily they came from two studies. So we have the ANSPS, which is an annual cross-sectional serobehavioral survey conducted among people who inject drugs attending needle and syringe programs, and this has been happening every year since 1995. And then the STOP-C study, which occurred over 2014 to 19, which assessed feasibility of hepatitis C treatment as prevention in prison settings in New South Wales. So with all models, we did make some assumptions, but really grounded in data. So based on data from the ANSPS, we assume that incarceration dynamics, the hepatitis C epidemic, and demographics of people who inject drugs are stable in 2010. So that's really when we start our modeling. The rate of treatment among community people who inject drugs is assumed constant until 2015, and then we calibrate an increasing proportion of an increasing treatment rate based on the proportion of people who are antibody positive that have reported ever receiving treatment in the ANSPS. In terms of prison, the annual number of people who inject drugs treated is assumed to be proportional to the total numbers of treatments started in New South Wales prisons. So this increases from 80 in 2010 to 1,500. So we then calibrated the model using something called approximate Bayesian computation, and this is methods that allow us to capture uncertainty in any of the model inputs or calibration data and propagate those into the model projections. So we calibrated the model to incarceration data, data on the proportion of people in each duration injecting categories, data on the hepatitis C prevalence, and also the proportion of people that have been treated, and then finally data on the OAT coverage, both in prison and in the community. So with our calibrated model, we then can do our model analyses, and we first look at what we call the transmission population attributable fraction, or TPAF, of incarceration to hepatitis C transmission over 2020 to 2029. So this is a measure of how much incarceration is contributing to hepatitis C transmission. So to do this, we compare a status quo scenario where we assume treatment OAT continues as it is, and that the risk in prison and in the recently released compartments of the model are different to others. Now we compare that with a counterfactual scenario where prison does not affect transmission risk, either in prison or immediately after release, and we see the difference in the number of new infections. We then looked at the historical impact of prison-based interventions. So how have these interventions impacted the epidemic? And we do this by comparing our status quo with alternative scenarios in which either prison-based OAT or hepatitis C treatment do not occur from 2010. And then we looked at the role of prison-based interventions for hepatitis C elimination. So to do this, we project what reductions in hepatitis C incidence could be achieved compared to 2016 going forward, and ask, will hepatitis C elimination be achieved by 2030? So we do this for the status quo scenario where prison and community treatments and other interventions continue as is. And then we see how important prison-based interventions are by turning these off. So how does that affect the date that elimination will be achieved? And then we looked at what happens if we improve interventions in prisons, either by scaling up hepatitis C treatment by 44%, as has been achieved in STOP-C, or by introducing needle and syringe programs. And then we did this again, all of this again, but looking at what would happen if community treatment rates were to decrease by 25% going forward. Okay. So some results. In 2020, the model suggested that 7% of people are currently incarcerated and 53% have ever been incarcerated. Whilst in prison, people who inject drugs have between 0.6 and 1.9 times the transmission risk of those in the community. So this really shows that we're capturing uncertainty in this model parameter. Those that have been recently released have between a 2.6 and 3.8 times transmission risk of others in the community. And then what we find by removing these differences is that around a quarter of infections could be averted over 2020 to 29. So this means that incarceration is contributing just under a quarter, so 23% of new infections over the next 10 years. What we find in terms of the historical impact is that actually the prison-based interventions have mitigated most of these increases in risk due to incarceration. So in 2019, these interventions avert around 16% of new hepatitis C infections. What we find since 2010 is that if these interventions hadn't occurred over the last decade, the incidence would now be around 30% higher. So they have dramatically reduced incidence, and that's incidence overall, not just in prison. And it's prison-based treatment for hepatitis C that's really had the biggest impact over this time. When we look forward and look to see whether hepatitis C elimination can be achieved, in the top panel, this shows the dates. These box whisker plots show the date in which an 80% reduction in incidence will be achieved compared to 2016, with the numbers showing the probability that this will be achieved by 2030. So if community treatment rates continue and prison-based interventions continue, there's a 98.8% chance that elimination will occur by 2030. But you can see if we remove interventions from prison going forward, that this probability jumps right down to 10%. And most of this is due to the effect of hepatitis C treatment in prisons. So prison-based interventions, primarily treatment, will have a massive importance in achieving elimination, increasing the probability from 10 to 98%. So if community treatment rates continue, improving those prison-based interventions, such as introducing needle and syringe programs or scaling up prison-based treatment, has a little effect. It does increase the probability, but there's not much place to go by from 98.8%. But it does shift the date of elimination earlier. Conversely, if community treatment rates were to reduce, you see a slightly different thing. So now there's only an 85% probability of elimination occurring by 2030 with existing interventions, but without prison-based interventions, it's virtually impossible to achieve elimination by 2030, as with those community treatment rates remaining 25% lower. Here now, introducing needle and syringe programs or scaling up prison-based hepatitis C treatment dramatically increases the probability that elimination will be achieved on time. So we then, this is still sort of work that's sort of being finalized, looked at the cost effectiveness of scaling up prison-based hepatitis C treatment. So to do this, we expanded our model to include those that have ceased injecting drug use and also hepatitis C disease stages. So this figure just shows disease stages that we include. So we have different levels of fibrosis, decompensated cirrhosis, hepatocellular carcinoma, and then liver transplant and post-liver transplant. So in order to do a cost effectiveness analysis, we need health utilities and costs. And so we use quality of life utility data that's stratified by the incarceration status, so whether people are in prison or the community, and then also by drug use status, so whether people are currently injecting or have ceased injecting. And we primarily used real-world quality of life data from 2 Australian studies. So these both collect data using the EQ5D5L tool. And it was the EFOS Engage study providing estimates in the community, and SOPC study providing quality of life estimates for the prisoners. In terms of costs, we include costs for both for hepatitis C diagnosis and treatment, but also hepatitis C disease-related care, because by treating people early, you can avert later disease stages and avert these costs. Okay, so to calculate the cost effectiveness of scaling up prisons, we compare our status quo scenario, so that's our business as usual, so current rates of treatment occur, continue, with an intervention scenario, which is where hepatitis C treatment is scaled up by 44% for 10 years, and then reduced back down to pre-scale-up levels. So again, this 44% is what was achieved in Stop C prisons compared to other prisons in New South Wales. So for both scenarios, we assume that community treatment rates will continue as is, although this is tested in sensitivity analysis. We take our costs and quality adjusted life years, or QALYs, for each of these scenarios, discount them at 5% per year, and sum them over 2021 to 2060, what's called a time horizon, so a time horizon of 40 years. We then calculate what's called the incremental cost effectiveness ratio, which gives us how much does it cost to gain a QALY. We compare this to a standard willingness to pay threshold of 50,000 Australian dollars. So we find that scaling up hepatitis C treatment in prisons is highly cost effective, with an ISA of just under $13,000 per QALY gain, so much lower than the 50,000 willingness to pay threshold. And we actually find that in every model simulation, the base case assumptions for the cost effectiveness, that scaling up treatment would be cost effective. So there's two ways of showing this, but if you just look on the figure on the right, this shows each individual simulation by process, and anything falling below a dashed line would be cost effective. So you can see that every simulation is cost effective. So then we did a number of sensitivity analyses where we varied things such as the discount rate used or the time horizon. And in all cost effectiveness, in all sensitivity analyses, scaling up prison-based treatment was highly cost effective. And one thing to point out is that actually what we find is the more prison treatment can be scaled up, the more cost effective it would be. Okay. So to conclude, incarceration is estimated to contribute between 1/5 and 1/4 of new infections among people who inject drugs. Now, prison-based OAT and hepatitis C treatment have mitigated some of the increase in transmission risk associated with incarceration. We find that going forward, prison-based interventions, and in particular hepatitis C treatment, will be pivotal for achieving hepatitis C elimination among people who inject drugs. But further scaling up of prison-based hepatitis C treatment could be important for achieving elimination if community treatment rates decline. And this would be highly cost effective, even if community treatment persists at current levels. I'm thinking just a little bit broader. New South Wales has high levels of community-based opioid agonist therapy, needle and syringe programs, and DAA therapy as well. And yet, even in this setting, prison-based interventions are still absolutely pivotal for ensuring elimination targets can be achieved by 2030. So I think what this tells us is that hepatitis C elimination plans that focus only on the community are likely to be unsuccessful. Now, most countries don't provide prison-based OAT, or the coverage is very low in prisons. And the majority of national elimination plans do not encompass interventions for prisoners. So I think this is something that really needs to be rectified. Finally, I'd like to just acknowledge all my co-authors and just say my email address there is at the bottom of the screen, and I'm happy to answer any questions that people may have. So thank you.
Thanks very much for sharing that video of Jack, Richard. We're going to move straight on and ask Richard actually to give the second presentation. Can I just encourage you though, if you'd like to ask some questions, unfortunately Jack won't be able to answer, but I was involved in Jack's, both of those studies, so I can give it my best shot to respond if you'd like to ask. And fortunately for us, Richard is here to do the same for his presentation. So can I just, for those of you who don't know Richard, he's a senior research fellow here at the Kirby. And his research focuses on mathematical epidemiology and the use of models to investigate transmission of infectious diseases across many different sectors. And the key aim of his research is to evaluate the impact of existing and planned public health strategies to inform policy directions. So thank you so much, Richard. To change the theme a little bit across to COVID-19.
Thanks very much, Andrew. I hope you can see my slides and hear me loud and clear. Thanks for the introduction and the invitation to present today. And yes, as Andrew said, I'll be presenting on everyone's favourite disease over the last couple of years, which is COVID-19, and some modelling work we've done since the start of the pandemic, really, to about the end of last year on potential interventions for COVID in Australian prisons, in particular in New South Wales. I actually got to start. I just want to do some acknowledgements to start with, because I guess there's a small team of us who are doing the modelling work, and in particular I want to shout out to Amy Kwan and Neil Britannia, who are at the Kirby, or used to be at the Kirby, who did the bulk of the work in model development and generated the results I'll be presenting today. And I also just want to highlight that this work has really been done in a lot of collaboration with Corrective Services New South Wales and the Justice Health and Forensic Mental Health Network, and they were providing advice throughout the whole period to ensure our modelling was of relevance to the correctional setting in New South Wales. And finally, there was a few other helpers along the way, and I'll just give them a shout out as well. So to get started, I guess most of you can probably imagine that in correctional settings, or what I'll term as prisons, particularly prone at high risk of having SARS-CoV-2 outbreaks and issues with COVID-19. And they are a high priority setting really because of the risk given the environment, and I guess unavoidable close contacts. We've got people in closed, tight settings, low ventilation, lots of interactions potentially, and lots of movement of people around the prison system and between settings and different environments. Another issue with prisons is that inmates are particularly vulnerable to COVID-19 because they have a lot of the morbidities already that increase the risk of adverse outcomes, and there's a lot of underlying health conditions in inmates. And I guess these risks have been realised, and there's, outbreaks have been seen all over the world within prisons right from the start of the pandemic in March 2020. But in Australia, I guess early on, we didn't have many outbreaks. In fact, there was no real outbreaks within a prison during 2020. There was some cases amongst correctional service staff and inmates sort of entering, but responses were put in place to prevent sort of an outbreak occurring within the prison until around mid-2021 or August, with the arrival of the Delta variant, where we started seeing outbreaks occurring in prison transmission. I guess since Omicron arrived, I guess there was a lot more outbreaks happening. There's numerous outbreaks since then, and I guess reflecting the higher transmissibility. But I think these tend to have been, as far as I'm aware, small and quite manageable. So I guess that's setting the context. I just would note there's been quite a lot of modelling studies done looking at in COVID-19 and in prisons, and this was, people started putting up preprints very early on. I would say this international work has tended to be focused in US prisons or the UK, with some in Europe. And I would say there's a tendency for these studies to look at like an individual single prison, or maybe a small number of prisons with some movement between them, and a focus on sort of individual interventions. So sort of taking a look at an individual intervention at a time approach. And I've presented a few examples of papers that have been published that are quite interesting around this. But one thing I want to highlight is that these studies haven't, I guess, looked at an overall response where they're combining multiple interventions and maybe considering how the response is actually occurring within a country or within a setting. So with our work, we're very engaged with Corrective Services New South Wales and the Justice Health network to make sure that any scenarios and interventions we implemented were kind of based on what was happening or what was planned to happen. And I would say, as I said, these are sort of individual prisons sort of modelling and not looking at a whole system where you've got a lot of interaction and movement between prisons or between prisons and the community. So what work have we done? So since the start of the epidemic, as I said, we were contracted really from, I think, about March, April 2020 by Corrective Services New South Wales and the Justice Health Network to model the potential for our COVID outbreaks in prisons. And our aims really, their aims and our aims hence, were to assess potential impact of interventions in response, to gauge how well protected facilities were from a Delta outbreak when Delta appeared and started causing outbreaks. And then with vaccinations, vaccines becoming available. So if you could vaccinate a number of people, what sort of coverage would you require and what interventions could you potentially ease so that you wouldn't have to have such burdensome restrictions necessarily on your inmates. And I guess these aims evolved over the time since the start of the pandemic, and this is more of the aims sort of in the middle of last year. Since the start of the pandemic, we developed 2 models to provide guidance around these. I'm going to talk a little bit about both of these models soon. And I guess the interventions of interest have probably sort of evolved over time as well as new technologies became available. But you're looking at sort of early release and deferral of inmates coming into prisons to reduce the population. And then you got all your sort of strategies around isolating and quarantining inmates on entry, mask use, making sure people who are sick don't turn up to the prison. We had thermal screening early on, and then eventually sort of rapid antigen testing and vaccination. I guess in 2020, when we started doing this work with no outbreaks, I guess these sort of theoretical results, but with Delta coming in, we did have something to compare to, our results and model outputs to compare to. And I would just note, we haven't done anything really with Omicron. So all I'm presenting here is sort of Delta variant focused. So just, I'm not going to go into too much detail about the models. I'm going to focus a little bit more on this model 2. But just to highlight that we did 2 models. The first model, which was developed by Amy, is a spreadsheet model, and this was designed for a single correctional setting, and was sort of designed to generate quick results because people wanted answers very quickly, and for something that could be played with by sort of non-modelers, so people from a correction, working in the correctional system. It's debatable whether we achieved this. I think over time the model sort of got more and more complex and the spreadsheet got more and more complex, but I think in principle, anyone who can open a spreadsheet can play around with the model. And so I guess the advantage is it's quick to produce outputs and look at combinations of interventions and scenarios quickly. We have made it open source, so it's available here on the Kirby Institute GitHub page. And I would note it was inspired by this model developed by Recidiviz, which is an organization in the US looking at incarceration in the US. But I think we ended up revamping it completely. So I guess they gave us an initial helping hand, but we made it much more complex and more directly relevant. And I guess here's the publication. I would note this journal, Advancing Corrections, can be a bit hard to access sometimes. So here's the preprint. So I guess most of my talk is going to be about model 2. And I'm going to provide a bit more detail about this. This one was developed by Neil Britannia, and it's a much more highly detailed individual-based models to look at movement within prisons and between prisons and to try and capture some of the effects of internal structure within a prison. And it does mean we can focus a lot more on individual interventions and interventions related to population movement. And it is a stochastic model, so it can sort of assess risk and probability of things happening, where these sort of spreadsheet models use sort of classic SIR sort of based compartmental model, looking at a population overall. I guess I've quickly put up a model comparison here. I'm not sure how easy this is to read for people, for everyone, but a couple of things to point out. I guess both models do try to look at similar interventions, but the individual-based one sort of can do things in much more targeted and precise sort of way, you know, making sure your quarantine is exactly 14 days or 15 days, and if testing's going on in quarantine and things like that. As I said, the spreadsheet model is very user-friendly, can produce outputs basically instantly. The individual-based model, despite having, is great because it has all this complexity and details, but it does require a coding know-how to run, and it can take a long time to generate results. So I guess we sort of had a balance here of the two models, one to help quick results, to give insight quickly, and then a longer sort of process to develop scenarios that are much more detailed with the individual-based model. So I guess I'm going to go into some results soon, and I guess basically what we did here was really looking at scenarios around interventions and to see how bad things can get. Luckily, we never got scenario 4 occurring in our modelling, but because that would have been particularly horrendous. But anyway, so from this, I'm just going to show one slide of some results from the spreadsheet model to give you a feel for what it can do. So as I said, with the arrival of Delta, there was an outbreak in the Metropolitan Remand and Reception Centre in Sydney. And this graph here is showing you, on the left is showing you sort of the cases that occurred in MRRC that are attributed to within prison transmission, and so were acquired by inmates within the prison. I would note that during this time there was multiple entries of community-acquired infections from staff and from other inmates entering the system. So I guess there's quite a complex sort of epidemiological curve here, which I'm not showing all of, and I would say that vaccination started in the outbreak. The blue line here is our model output, and this is a simulation where we tried to have the interventions that were in place before the outbreak, which were sort of PPE, isolation, quarantine. There was no vaccination, and I feel, and we just had one sort of inmate enter that was infected and spark off an outbreak. And I feel the model doesn't do too bad a job. It maybe overshoots a little bit, though we do miss this one day of lots of cases. And we don't see the decline, probably because we haven't got vaccination implemented. But I think it's not a bad job. And one thing to note is also we don't have the structural features of the prison there. And then on the right, I guess this is some example scenarios, essentially showing you sort of all your various classic epidemic curves with each of these interventions in place, and then with combinations of interventions as well. I guess the message here, and this is amongst inmates, is that so all these interventions can provide a bit of reduction. Quarantine maybe does a bit less than you'd expect, and I guess this could be a limitation of the model where we do have leakage sort of occurring, which may be real, but once it sort of escapes a quarantine, you do have a big outbreak. I guess bottom line is combination of interventions can reduce outbreaks substantially, and then with your add vaccination in, you're sort of protecting the prison from Delta. I guess other aspects from the model is that we can look at staff leveling and see how many staff are infected and who couldn't become to work given they're infected. And you can see, you know, up to 50% or more staff could be out of action due to infection if you know, sort of thing, COVID was allowed to run rampant in the model. I guess I just presented that to give you a flavour of the spreadsheet model, but really I wanted to focus on the prison model, because I think this is quite unique. As I said before, not aware of anyone trying to model a whole system. And this model, I guess, the reason we were able to generate this model is that Neil had already developed a sort of system-wide model for hep C transmission. And so he built, from that, he built in SARS-CoV-2 transmission and a lot of other details from that, from where he was with hepatitis C. So this model does include all prisons in New South Wales. I think there's around 56 in the model, and it includes movements of inmates between prisons and to court and backwards and forth and entry from community. includes internal structure of prisons. So you got your cells, which have 1 or 2 people in them, then your units, up to areas and wings, and then the whole prison itself. We did try to get data on, what the population was in each prison, age and potential Indigenous status and things like that. As I said before, it can capture individual events and specific interventions. I'm going to go through these in the results. I guess I'm just showing you here some examples. We didn't do contact tracing actually in the prisons. I don't think they really thought about doing contact tracing per se. I know as an intervention, a lot of it was more focused around isolation, quarantine, scaling up vaccines, and PCR and rat testing. So here's a schematic, I guess, of the information I just showed you. So I guess in principle, what happens is people enter from the community. This is sort of looking at inmates. I guess we have staff on the side as well. And then they enter the prison system, and we've got minimum, medium and maximum security prisons. And I guess these numbers here are the sort of averages across these, the prisons in each of these categories, but you have your areas, units and cells. People can move in between the prisons via buses or trucks, and then they can attend court and go to and from the prison to court and back. And I guess these are interesting avenues for transmission is because as inmates are moving between prisons, they often, there's a pickup and drop-off system. Many inmates from different prisons can be congregated together in a closed space, either at court or on the bus. And so hence there's avenues there for escalated risk of transmission and spread across the system. I think the schematic diagram here of the disease progression is fairly standard for COVID and probably what you've seen before. So I'll move on. I was just gonna provide a little example simulation of what happens in the model. So this is an example where MRRC had an infected inmate enter. It was under a situation where lockdown would occur once detected. And essentially what you're seeing is this growth here, and there was a detection, which meant sort of a rolling lockdown system that infected inmate could then spread through transfers to other prisons, which caused little outbreaks there before lockdown happened. And then I guess lockdown sort of prevented it spreading more widely. But you still had quite a big outbreak in the original prison. Just thanks to Alex Walton for actually doing the video here. And I just would note the results here are sort of little toy results to just demonstrate sort of the principle of the spreading between actual prisons in the system, and they're a bit out of date. Okay. Whoops. Okay. So, and then just a quick comparison to the MRRC outbreak. So this is a bit of a messy graph, I'm sorry. So the blue dots here are the same data as I showed before. The squiggly lines here are individual simulations of this model. It was run 100 times, with 92 having outbreaks. I guess the point here is just to show it maybe undershoots a fraction when we have PPP, isolation and quarantine in place, but you're kind of getting sort of peaks and troughs that are in the ballpark of what was seen in MRRC. One thing to note, I guess, is that with these simulations, we're continuing to get reseeding occurring within the prison due to prisoners entering from outside and from other prisons that may be infected as it sort of spreads around the whole system. But I guess the point here is just to sort of say I feel like we're getting in the ballpark with where the model was, and this is reasonable validation. So just with the results. So a few slides of results. So this slide here is just sort of showing you sort of no response. So if we didn't do anything and we had alpha variant, delta variant, or Omicron variant enter the system. I did say we didn't do any Omicron things, but this is really here just to show a more transmissible variant. And you can see sort of the higher peaks in outbreaks across the system. I guess with every variant in each situation, you essentially get everyone in the prison system infected with no responses occurring. One interesting part is that it sort of doesn't matter if it's an inmate or staff member who enters with an infection. They spark similar outbreaks. However, family visitors or people sort of just visiting sort of for one day and maybe only interact with one or two people, very low risk of an outbreak occurring. And this is kind of important because family visitors, there was restrictions on family visitors and other visitors to inmates during during the lockdown over 2020, 2021 period. So, and there was a lot of concern about that with isolation and whatnot. So I guess we found in the model that there would be low risks with family visitors being allowed to attend. Next slide's, I guess, around sort of masks, PPE and rapid antigen testing. I guess with the individual-based models, we can look at a lot of different masking strategies using standard masks versus N95, who wears the mask, staff working in quarantine and isolation areas, maybe have more protection than elsewhere. I guess the message here is really that it can have an impact, especially with sort of quarantine and isolation here, can have a big impact when you sort of have all the non-pharmaceutical, non-vaccine interventions in place as they were in the system at the time. Rats are kind of interesting. I guess there's a policy of testing healthcare and correctional staff daily with a rat test before they arrived. And you can see that this really prevented an outbreak occurring if you detect using daily rats, but using every second day, for example, or less frequent, you could end up a staff member entering the prison while infected and sparking an outbreak. The testing staff had some impact on inmates, but I guess not a huge impact. It did reduce the outbreak among inmates a little bit, but I guess as you'd expect, you're sort of protecting staff, but not necessarily protecting inmates once that happens. And finally, just here, I guess this just sort of showing you examples around if you do pre-transfer testing and other things like that, or have mask usage during while people are in the bus, everyone's wearing a mask and they've been tested, that can have effect as well. And I guess, if you restrict all sort of transfers and movements, then you can obviously sort of isolate the prison where the outbreak occurred and not have a spread amongst the system, as you'd probably expect. In terms of isolation and sort of lockdown type strategies, I guess these were sort of implemented as rolling strategies where, you sort of lock people down, isolate them in their cell as they're sort of diagnosed, or you sort of isolate a unit that contains someone who's diagnosed, or area or prison. There's always a chance of someone who's asymptomatic or hasn't been sort of diagnosed yet, sort of escaping or interacting outside these areas, so you can still get spread of infection through the system, but I guess it's much reduced. And similarly, if you delay sort of when you can get everything into shape to implement those sort of isolation strategies and things like that, then you have less effect. And, I guess you sort of got to try and get things going within a week, essentially, to really mitigate the potential spread within a system. And then vaccination, of course, was kind of key. And we did look at vaccination, looking at different coverage levels. I think one thing is that for staff working in the New South Wales prison system, it was mandated that they had to get vaccinated. And so I guess the reference group said that 100% vaccination was going to occur among staff. And as you'd expect, we get, greatly reduced outbreaks, I would say, but not completely prevented actually. So even high coverage among inmates and staff doesn't prevent outbreaks occurring unless you add some extra sort of responses or non-pharmaceutical things like quarantine or isolation to the thing, and then you can prevent and mitigate outbreaks. I'm not sure if I'll worry about going into this slide too much. This is just sort of giving you a sense of, what different scenarios can lead to lots of prisons having small outbreaks versus one prison having a big outbreak, and things like that. But I don't think I'll worry about going in the interest of time going into that in detail. And I'll just go to some conclusions to finish off. So I guess, essentially, as I said, if you have no public health response, you essentially get everyone infected quite quickly. So pre-Delta, before Delta variant arrived, it did seem like having restrictions in place led to a low risk of a sustained outbreak, and that's kind of what we did see. in New South Wales and I guess Australian prisons. The main entry points of infection are really around inmates and staff. And we said, like I said, family visits have a low risk of sort of starting outbreaks, and there's other ways of potentially mitigating the risk that's there. I guess the modelling showed that outbreaks were likely to happen with the arrival of Delta prior to vaccine rollout. And again, that's sort of what we have seen or did see. And then things around PPE for staff and inmates, assuming it's used correctly and everyone's very adherent to that, it can lead to a large reduction in the size of outbreaks. And then, as I said before, frequent RATs for staff can be very effective at preventing infections entering the prison via staff. But I guess once it spreads to inmates, then they're not that helpful. And we also found that testing inmates prior to transfer was also very effective in reducing the spread of COVID across the system. So I guess testing people and keeping them in their where they are is found to be positive, and putting them into isolation. And yeah, high coverage vaccination coverage does allow easing of quite a number of restrictions, and probably most of restrictions actually, but it's still not enough to prevent outbreaks occurring, was what we found. So you still need to have some things in place, even with a high vaccine coverage. And just to wrap up, just go to the acknowledgements again, and highlight Amy and Neil and Andrew and the Corrective Services New South Wales and Justice Health reference group, who provided a lot of input and advice on these model into this work. Thank Alex for producing the video, Andrew and Warren from Recidiviz, just helping us with their original spreadsheet model, and James Wood and the other modelling people at Kirby for lots of advice throughout, and David for doing a nice review of outbreaks early on when we were getting started. Thanks, everyone.
Thank you so much, Richard. That's great. So can I encourage the audience now to, once again, to put questions in the Q&A box if you'd like to. I've got a couple of, or sort of tidy up kind of questions. I can see that Alan's asked, has the research been published? And I think that question arrived when Jack was still presenting. And I can tell you the first part of his presentation has, the paper's just been accepted in Liver International. And the second part, the cost effectiveness, is still in progress. Alan also asked, would there be an article in the conversation? I would say there could be. And Alan finally asked for us to share the link. So Richard had a couple in his slide set, so we could put them into the chat, no troubles. I might, if I can, Richard, take the liberty of asking you a question, first of all, about I guess just in general, the modelling of COVID, and whether or not you feel that it might be relevant to other pathogens, other respiratory pathogens, or could have told us that the Ruby Princess was going to be a nightmare as well.
I'd say yes. I guess there's sort of, in terms of other pathogens, the model's quite general. Obviously, the disease progressions can be a bit different to other respiratory infections, Andrew, but I think sort of the lessons learned for the next pandemic, based potentially on influenza or a coronavirus, are there still and relevant. I would also say the model is actually, this modelling is relevant to congregated settings or closed environment settings, potentially for aged care, for example, where you've got people within a setting living close together and staff coming and going every day. I guess Ruby Princess, it could be applied to a similar sort of cruise ship situation. I guess the staff aren't going, everyone's sort of locked in for the whole journey on the ocean. But yes, and I guess Amy's spreadsheet model, we do call it a closed population model, actually. So it really just needs a tweak of parameters often to make it relevant to a setting.
A couple of other sort of detailed questions to Richard. One would be, I think you alluded to one scenario, I think it might have been Amy's model, which was about deferral or early release. Yes. Well, yes. I wondered what's that about?
Look, so I guess people were looking into that, and a lot of interest in that, because it reduces your susceptible population in the prison. So, for example, you know, if you have 1,200 people in the prison, but you can reduce it down to 1,000 by sort of releasing people who are low risk to the community early, or stopping people maybe deferring their entry into the prison system, then you've got less people susceptible and therefore less, a smaller outbreak.
But do you reckon it's just numerical, you know, as in there's less susceptibles that are exposed, or is there a value add, so to speak? I'm thinking overcrowding.
Oh, yes, I guess so. I mean, I guess I'm coming from a non-overcrowding side, but yes, if you're preventing overcrowding, obviously overcrowding would probably exacerbate transmission, you would think, and people being sort of stuck in very enclosed spaces, lots together. You'd imagine super spreader events occurring for sure in that situation. So I think there's a lot of thoughts early on in many settings about trying to do that type of thing. And I do know there's one sort of bad example of it happening in California, where they were trying to transfer inmates from one place to another to prevent them being at risk, but they didn't know they had COVID already, so they ended up transferring it to other prisons rather than protecting.
That also has some reminiscence of the Ruby Princess, doesn't it? Weren't they let off the ship to infect everybody else?
Yeah, but I think wasn't it? Oh, geez, I'm trying to remember. I think it was a lot of already occurred within the ship, and they're not so much outside after they were let off. But anyway.
I'm aware too, Richard, that the family visits thing, in the midst of the epidemic where most of the prisoners spent many hours locked in their cells, the idea of not being able to see their family was something potentially riot-inducing. So should we be surprised that the family visits were relatively less risky, so to speak? Probably not. I guess, you know, what you're thinking is family visitors coming in maybe just to see one person or whatnot, maybe like, and in a separate area in the prison, as far as I understand. So, you know, they're not having many contacts. So if there was an infection amongst the family visitors, they're sort of only really having one contact, maybe over a short amount of time. Before going back, where in a prison, there's a lot of contacts happening between staff and inmates every day. So you would expect a lower risk there. And I'd say it's kind of maybe relatively easy to mitigate the risk there could be there as well. Like, I mean, having enough distance or screens or other aspects, making sure people are vaccinated, that type of thing. PPE, would sort of I'm just looking at the Q&A too, Richard, and Alan's asked this great question for you.
Oh, okay.
About data sharing. He said this he says, is
the international standard for sharing epidemiological data. I feel like that could be out of my remit a little bit. I know the surveillance team would probably have a lot to say about that, and others.
And modelling, Richard, my sense of the data sharing in the modelling world is pretty good, actually, particularly with vehicles like GitHub.
Yeah, I think it's really driven everyone to suddenly share their code and make things open and find the bugs and let me know if I've made a mistake kind of situation. I'd almost say it's standard now for any modelling, epidemiological modelling that you do, is you kind of need to provide a link to your model.
So that's a COVID consequence, is it?
I think there was a lot happening beforehand, but COVID probably really made it prominent.
Right.
Yeah. I mean, I was doing it before COVID, but I think kind of, a lot more people started doing it and things like that.
Fantastic. So I think we've reached time. Can I just thank Richard, on behalf of the audience, can I thank Richard and previously Jack to spend the time to make the video and make it available to us. It's been an interesting insight both into the prisons and into the potential for modelling. So thank you so much. And we'll finish there. Thank you.
Thanks, everyone.